There we go. Is it in here? This is good. Have to start it.
In charge of texting Dr. Morris and telling him it's up and going.
Oh, okay.
But I'm not going to be able to do this. Right?
Yeah.
Now a black screen. Oh, we're good.
Yeah. Yeah. Awesome. Thank you.
Good afternoon, everyone. I'm Mike Lazar, and I'm going to give the second of two talks on pulmonary function testing. The first talk I gave was on spirometry and the testing that goes along with spirometry. Today, I'm going to give an overview, rather, of lung volumes, diffusion capacity, and other ancillary tests that we do in the lab. So today, as I mentioned, is part two, in which I'll talk about lung volumes, diffusion capacity, respiratory muscle forces, and the scattering of other tests that we do. So the objectives today are no different than the ones we had before. I'm going to review the various components and measurements of pulmonary function testing. My hope is that by the end of the talk, you'll understand the information that gathered by pulmonary function testing and understand how the basic physiology and pathophysiology is reflected in the testing that we do. And lastly, we'll try to integrate some basic understanding of pulmonary function into clinical contexts. As the last time, I just wanted to offer acknowledgement to Dr. Morris for the time he spent reviewing stuff with me, offering me articles to read, and spending time teaching me the ins and outs of the lab itself. Today's talk would not have been possible without him, because a week ago he reminded me that I actually had to give it. So I want to thank him for allowing me to finish the slides and then practice the talk earlier this week. So the first topic today that we're going to talk about is lung volumes. And the most common way that we do lung volumes in our laboratory here is something called body plethysmography, where you can see here on the slide, there's a person sitting inside of a body box in which they have a pneumatech and that measures all the stuff that you blow out. There's a shutter on the machine itself. The patient has nose clips, and the box is completely sealed. So it's a sealed airtight chamber that we use, and pressure is measured both at the mouth and in the chamber. At the end of a tidal exhalation, so patients are tidal breathing, then they exhale from that tidal exhalation, you're now at functional residual capacity. And the patient will then pant against a closed valve or the closed shutter, causing both thoracic compression and then subsequent decompression. The changes in the lung volumes are reflected as changes in thoracic pressure and changes in the box pressure. And these changes allow for the calculation of functional residual capacity, which is often expressed in the guidelines as TGV or total gas volume. This is effectively what the respiratory therapist is doing. So the respiratory therapist will have the patient do quiet breathing throughout in the early part. Then eventually at the end of an exhalation, they'll close, at the end of a tidal exhalation, excuse me, they'll close the shutter. Then they'll actually ask during this section here for the patient to pant in and out against the shutter for a finite period of time. The panting maneuver is to measure the thoracic gas volume at time 1, or functional residual capacity. Let's go through a little bit of math here, and I assure you I'll try not to bore you too much on this stuff. If you remember all the way back to high school chemistry, the pressure at time 1 times the volume at time 1 is equivalent to the pressure at times 2 times the volume at times 2. That's Boyle's law. So what we do in this circumstance is we take the alveolar pressure at times 1 minus water pressure multiplied by the thoracic gas volume at time 1. This is the number that we're interested in calculating over here. And then what we'll also measure is the pressure at alveolar pressure at times 2 minus the pressure of water times the thoracic gas volume at times 2. In this equation here, the guidelines basically are identifying the pressure, alveolar pressure at times 2 is basically alveolar pressure at times 1 plus a delta P or delta pressure. And thoracic gas volume at time 2 is the time 1 volume plus a delta volume. And then we just elongate out the equation. In 3B, the next thing that we'll do is take the thoracic gas volume at times 1 and then put everything else on the other side of the equation. And that equates to the negative change in volume over change in pressure times the alveolar pressure at times 1 plus the change in pressure. This value here is the information we get from the panting maneuver. So the respiratory therapist will do a panting maneuver, and then you'll get a slope line here that will allow for them to plug that into the equation here. Through some mathematical hopscotch, there's really not a significant change in pressure because you're in an airtight chamber, so with that drops away. And alveolar pressure at times 1 is roughly equivalent to that of barometric pressure. So the thoracic gas volume at times 1 is equivalent to this panting maneuver slope times barometric pressure. And thoracic gas volume is equivalent to functional residual capacity. That's a lot of mathematical hopscotch. So after the shutter valve is then open, the patient will then breathe tidal breathing again. And then at the end of a tidal breath, they'll blow all the way out until there's no air left in the lung. That's the expiratory reserve volume here. That's measured and subtracted from the functional residual capacity to give you a residual volume. At residual volume, the patient will then take a big deep breath in. That's the inspiratory vital capacity, and that will give you your total lung capacity. Lots of measurements over a long period of time. All right, let's switch gears for just a second. That's how the previous slide set was on how we measure volumes inside the body box. But we also do here at Henry Ford a nitrogen washout. The nitrogen washout is a little bit simpler mathematics in which the concentration of the gas at time 1 times the volume of time 1 is equivalent to the concentration of the gas at times 2 times the volume at times 2. Since we use nitrogen, we take the concentration at times 1, which is essentially equal to the alveolar concentration of nitrogen, or about 80%. This volume of V1 is the FRC volume. And then we'll measure the concentration at volume 2 and the volume, the concentration at time 2 and the volume at times 2 through a series of measurements that I'll go through just right now. So the patient will breathe through a mouthpiece with 2 one-way valves. Cool. The first is connected to 100% oxygen. That's part of the washout. The second is it'll measure exhaled gas, and then we'll measure nitrogen concentration through the exhaled gas. So the patient will start at functional residual capacity, breathe 100% oxygen, and exhale nitrogen-containing gas from the lungs into the device. The nitrogen level will be measured in the device, and then it will asymptotically approach 0. You will effectively wash out all the nitrogen in the patient's lung. The test stops when the nitrogen concentration is less than 1.5% for 3 successive breaths. And the initial amount of the nitrogen in the lung is equal to the total amount of the exhaled nitrogen. The problem with this test is theoretically it can potentiate carbon dioxide retention in individuals that have bad enough COPD. The other bad part of this test is that the volume of gas that's in a trapped bulla or unaerated part of the lung is not measured at all. So when you compare the two tests, body plethysmography is the most accurate, but it involves incredibly complex calculations and requires expensive equipment. The patient has to be able to hold their breath and pant too and follow those instructions. Gas dilution is easier for both the respiratory technician as well as the patient, but it will underestimate functional residual capacity and residual volume in patients with severe airway obstruction. So what are the values of static lung volumes? So in obstructive disease, you can actually identify hyperinflation and air trapping with these measurements. Air trapping is defined as a residual volume that's greater than the upper limit of normal and a residual volume to TLC ratio that's greater than the upper limit of normal. Hyperinflation is defined as a residual volume and total lung capacity that are greater than the upper limits of normal. Remember, we identify normality based upon confidence intervals, so the upper limit of normal is the confidence interval plus the normal value for an individual test. Restrictive lung disease is defined as a total lung capacity below the lower limit of normal. The problem with using total lung capacity, tremendous amount of mathematics that goes into it, and you actually have to pay attention to all the things that could go wrong during the test. Because of that, our confidence interval for total lung capacity are much wider than that of vital capacity. Vital capacities are directly measured by the respiratory technician. It's a simpler calculation. Therefore, in our lab, we will not define a patient who has a low total lung capacity but a normal residual volume as having restrictive lung disease. Neuromuscular disease is defined as an individual who has a decreased total lung capacity with an elevated residual volume. We'll also talk about something called complex restriction in the near future, in which a total lung capacity minus the vital capacity percent predicted, if that's greater than 10%, that's also can be indicative of neuromuscular disease. So many times we get asked, well, why is the total lung capacity not the gold standard? This is a test that was done several years ago. The first test thing that we did with our total lung capacity maneuver in the body box is we calculated the FRC through the series of complex equations and the panting maneuver. Then we asked the patient to exhale to residual volume to measure the ERV. That allows us to calculate the RV. Then we asked the patient to take a big deep breath in, an inspiratory vital capacity here, in order to measure that maneuver to add together to get a total lung capacity. That's 5 steps that could potentially go wrong as opposed to just a single step in which we measure a vital capacity. Let's make this even further more difficult. For our data set, we use the Intermountain Thoracic Society data that was generated in 1984 from Salt Lake City, Utah. 200 Caucasian Mormons from Salt Lake City. That's where the normality comes from. So the ATS-ERS statement says, well, you should adjust the predicted values by a percent to adjust for race. There are no measured normal values for African Americans. But what we do is we adjust by 0.88 times the normal value, which is the ITS value, to define it as abnormal. Well, what do you do with the confidence interval? So in that circumstance, what we do is we multiply the confidence interval by 0.882. So in a group of individuals in which there's no direct measurement, they actually have a narrower confidence interval than the individuals that have direct measurements. Lastly, I'll point to the guidelines themselves. So in Table 5 of the guidelines of standardization of lung function testing, under restriction, it'll say a low total lung capacity from a single breath test should not be seen as evidence for restriction. That's exactly what we do here. So in our interpretation system, as the fellows read the test, they'll say if the total lung capacity is low, but any vital capacity that's measured, whether it be a forced vital capacity, a slow vital capacity, an inspiratory vital capacity, or a post-bronchodilator vital capacity, restriction is not reported. So I spoke a few moments ago about complex restriction. This is something that's debated in the medical literature, but there's a study that came out of the Mayo Clinic in 2017 in which they tried to define something called complex restriction. So complex restriction is defined as a total lung capacity minus the forced vital capacity greater than 10%. In the Mayo Clinic, they took 40,000 patients from their database and they pulled out individuals that, pulled out 4,500 individuals that had restrictive lung disease. In those individuals, 2,400 of them had simple restriction. That's the vital capacity and the residual volume both went down in conjunction with each other. 511 of them had both obstructive lung disease plus restrictive lung disease. But then there were 1,600 patients that didn't meet the descriptive for either of these two and had a total lung capacity minus the vital capacity of greater than 10%. And this is what the groups look like. So if you divide them up by diagnostic criteria, you'll see some diagnoses in which you'll see the red bar, total lung capacity percent predicted, being much greater than the blue bar, which is the forced vital capacity predicted. There's a group of diagnoses that's associated with this. The first is obesity, WHO 3 obesity, which is anybody with a BMI of greater than 40. The second group is individuals with neuromuscular disease. Third group of individuals is individuals with occult obstructive airway disease. So individuals who have mosaic attenuation on their CT scan images, or perhaps over, as you can see here, bronchiectasis. And then there's a group here of pulmonary hypertension that also can be classified as these individuals with a change of total lung capacity minus forced vital capacity of 10%. So all restriction is not necessarily the same differential diagnosis. So let's spend a moment talking about airway conductance and airway resistance. So this is the gold standard for measuring airway resistance, which is labeled as RAW, or resistance of the airway, and that's been done in plethysmography. The airway resistance maneuver must be paired with a thoracic gas volume or a functional residual capacity maneuver. That we get that every time that we do lung volumes. Oops. This is a graph for airway resistance, conductance, and specific conductance. So as you can see here, airway resistance is a curvilinear shaped curve that goes downward from residual volume to total lung capacity. If you think about it logically, that makes sense. When the lung itself is not inflated, there's more resistance in the airways. As the lung becomes greater and greater inflated, as you get closer and closer to total lung capacity, your airway resistance goes down. Airway conductance, which is just the inverse of airway resistance, has just the opposite response, but it's linear. And then it goes up as you get closer to total lung capacity. The best value in all this is specific airway conductance, or SGAW. This is the airway conductance divided by the thoracic gas volume. That's a straight line across all lung volumes. So when you guys are looking at these PFTs, airway resistance being high should be taken in context with what does the specific airway conductance look like. Let me give you an example. Here's a patient that has normal spirometry. As you can see from this test, the airway resistance is really high. It's 271% predicted, and the red numerals in here denote that this is outside the confidence intervals. But I'll also point out to you that the specific conductance is normal at 60% predicted. Well, why is this specific conductance normal when the airway resistance is normal? That's likely because your functional residual capacity in this case is 52% predicted. This patient's airways aren't open up enough, therefore augmenting the resistance that when you correct for the volume of gas in the lung, it actually normalizes. Okay, diffusion capacity. I'm going to spend a little bit of time going through diffusion capacity because this is actually pretty important, and because we use this measurement a ton in our clinic, and we should know what the pitfalls of it are. So diffusion capacity is a measurement of gas exchange. Carbon monoxide has a high affinity for hemoglobin binding, but there's low constitutive levels in both atmospheric gas and within our lungs. The method for measuring diffusion capacity is a patient will exhale to residual volume, and then will inhale a volume of gas containing a very low concentration of carbon monoxide and a tracer gas. the tracer gas that we use in our lab is methane, and that's used to actually measure alveolar volume. The patient then is asked to hold their breath for about 10 seconds. We'll go through that a little bit more in just a moment. And then they'll exhale to residual volume again. The maximum amount of maneuvers that you want to do for each session is approximately 5. You start to see accuracy issues when the maneuver number exceeds 5. This is a DLCO sheet that the fellows are very commonly see in their sheet. We should be ultimately getting this when we order PFTs. Let me go through this sheet with you because there's a ton of data that's on it. The first is there's 3 trials at the top. They're labeled 1, 2, and 3. You'll notice that trials 2 and 3 are in the dark black numerals, and then trial 1 is in the gray numerals. That means that the respiratory therapists, for a variety of reasons, have grayed that out or not used that data point. On our software, the quote best unquote is actually not the best effort of the patient. It's the average of the trials that you've included into it. So you'll see that this 21.3 here is just the average of these 21.9 and 20.8 over here. The second piece of information you're going to see is this blue line down at the bottom here. This is the inspiratory vital capacity that occurs from residual volume when the patient is asked to take a big deep breath in to their total lung capacity. And just underneath this blue line is this dotted green line. The dotted green line denotes an IVC to FVC ratio of greater than 90%. So if the blue line is above it, that means it's greater than 90%. It's a visual way of telling in trial 3, did the patient achieve greater than 90% of the forced vital capacity during this inspiratory maneuver. You'll also notice at the end of the curve that there's an exhalation that should go all the way back to residual volume. In this case, you'll notice that there's a difference here between the 0 point and where this patient starts to plateau at. We'll talk about that more in just a second. This green line over here is the mouth pressure. When the patient is asked to hold their breath, the pressure is being measured at the mouth. And what you want to do is maintain an equal pressure at 0 throughout the entirety of the maneuver. And the last is the breath hold of the tracer gases, which is defined as the red line at the top. That ultimately branches into the blue line over here, which is methane. That measures alveolar volume. And then the red line, which measures diffusion capacity. The last thing I'm going to point out to you is this little hatch structure over here. This is the sample gas collection bar. This is where we open the machine and measure the amount of carbon monoxide that comes out during a finite period of time to actually calculate the diffusion capacity. Lots of stuff on this graph, lots of data that we're gathering during this test. All right, so during the DLCO maneuver, I made mention to you that we should talk about a breath hold time. The breath hold time is defined as 0.3 seconds into the inspiratory effort to the middle of the sample volume collection. The Jones and Mead method of measuring diffusion capacity assumes rapid assimilation of gas in the chest. The inspiratory effort, as you guys know, takes some element of time, so they just basically determine that 0.3 seconds into this maneuver is when you'll start the breath hold time, and then it will maintain up until about halfway through the sample sample collection time. That time should be between 8 and 12 seconds. And as I may mention, the inspiratory time occurs from the beginning of inspiration until about 90% of the inspiratory volume has been inspired. So a lot of times you'll see at the bottom of your paper on PFTs, the quality control measures of the PFTs. The quality control basically says, well, how accurate are the numbers that you're getting? So when you measure something, you should know if it's accurate or not. How do we determine accuracy? Reproducibility is defined by a diffusion capacity needing to be within 2 millimeters per millimeter of mercury per minute of each other. It has to this number has to happen, otherwise the test has to, another trial has to be done. The next thing that needs to happen is you want your inspiratory vital capacity to be 90% of your forced vital capacity. You want to know that the volume of air that you're taking in for the diffusion capacity maneuver is equivalent to that of your spirometric values. The next thing you want is the alveolar volume. That's again measured by methane, and that should be within 200 milliliters or 5% of each other. This is going to determine that your variability between tests is minimal. And lastly, you want to have your breath hold time between 8 and 12 seconds. All of these maneuvers are incredibly important because they're useful and they're used in calculating the equation to give you a number that you look at the bottom of a page. Let's spend a few moments talking about the sample collection time. So sample collection time must be completed within 4 seconds of the initiation of it. It's defined from the start of the sample collection here until the end of the sample collection over here. The sample collection time starts as soon as dead space is cleared. So you'll notice that there's an area in here that there's no measurement of any diffusion. Effectively, what this is is to clear out the dead space in the system. That's normally about 1 liter in individuals who are normal, but can be as low as 500 milliliters in individuals who have restrictive lung disease. If you move this bar and collect gas too soon, that means there's going to be less time for carbon monoxide to absorb, which means you'll have a falsely lower value. If you collect this too late, so you move this bar over to the right, that means you're collecting too late and you're giving carbon monoxide more time to absorb, and you're going to have a falsely lowered value, or excuse me, a falsely elevated value. Apologies. This is a chart that most of our fellows keep close at hand when they're looking at diffusion capacity maneuvers, and it basically defines how what the quality of the test is. We give it just like in grammar school, an A through F rating, and they have to meet patients have to meet certain criteria, testing has to meet certain criteria to be classified in any of these. But remember that the criteria for repeatability of the test is they have to be within 2 milliliters per minute per millimeter of mercury of each other. So when you're comparing tests from one patient to another, from one time to another, if you've got a D test on one time and an A test the next time and the numbers are vastly different, it may not be because the patient's physiology has changed. It may just be that the collection of the data has changed. So what does the DLCO mean? I just went through all this hullabaloo about how to collect it, what we're measuring. What does it mean when you're looking at a number on a piece of paper? Well, it reflects the transfer of gas from the lungs into the blood. So there are lots of things that can reduce a diffusion capacity. So DLCO can be reduced in decreased surface area for gas exchange. So emphysema, lung resection, pulmonary emboli, or pulmonary hypertension can do it. If there's an increased distance for diffusion, so ILD or congestive heart failure can do it. If there's anemia or a shunt in the lung, that can do it. Decreased cardiac output, we'll talk about that in just a few moments, and excessive endogenous carbon monoxide inhalation. There are very few things that actually increase a diffusion capacity. The classic one that people like to ask on a board examination is pulmonary hemorrhage. So if you have more red blood cells sitting in the alveoli, there's more area for carbon monoxide to glop onto, which means that the diffusion capacity will actually be improved. There's probably better ways to diagnose pulmonary hemorrhage than PFTs, but we'll leave that for a different time. You can see an increased diffusion capacity in very early congestive heart failure if you have cephalization and recruitment of vasculature without increase in diffusion distance across the interstitium. Uncontrolled airway disease can actually increase the diffusion capacity. The way that this works is when an individual is having an airway disease exacerbation, they'll generate significant force to try to move air in and out of the lung. When they do that, they have to create a more negative pressure inside the chest, and that negative pressure inside the chest will draw blood into the heart and into the lungs. When that happens, there's more blood in the chest for carbon monoxide to glop onto, which basically will increase the diffusion capacity. So it's not an uncommon occurrence that you'll see an individual come into clinic will tell you that they're worse in terms of their symptoms. Their flows have dropped, but their DLCO goes up. That's a pretty classic finding in somebody who's got an airway disease exacerbation. And obesity, through a same mechanism, individuals are breathing harder and faster to try to move air in and out of their lungs, can also increase the diffusion capacity. Although, frankly, if they develop pulmonary hypertension associated with the obesity, that will decrease the diffusion capacity. Okay, so I'd like to spend a few moments talking about false values in the diffusion capacity. You guys should know what things artificially raise and lower the DLCO during a test. If you're looking at a number and making treatment decisions on it, you should know how accurate the number is. So the first thing that can falsely reduce a diffusion capacity is a Valsalva maneuver. You can see here, this is the green bar that I talked about earlier. This is the pressure on the mouthpiece. And you can see that the pressure on the mouthpiece exceeds 20 centimeters of water going all the way up here. When that happens, the patient, that will increase intra-abdominal pressure, increase intrathoracic pressure, and reduce venous return. When you have reduced venous return, that will lead to a falsely lowered DLCO value. The second thing is if the expiratory time falls below the 0 line. So you can see here, here's your inspiratory, the blue line of the inspiratory vital capacity, breath hold, and then the exhalation. But you can see here that the exhalation drops below the line over here. That means the patient started their maneuver above the residual volume. And exhaled volume was larger than the inhaled volume. In doing that, the inhaled volume was lower than it should be, so less carbon monoxide was inhaled at the onset of the maneuver, leading to a falsely lower diffusion capacity. The last thing I'll talk about is the DLCO, the low inspiratory vital capacity. So if your alveolar volume, as denoted in this red circle here, is low, that will lower the diffusion capacity. The reason I haven't shown this equation before now is because anytime you use a natural log in any medical lecture, that usually drives people to sleep. So I'm going to ignore that. But the other things I'll point out to you is the T is the breath hold time over here. So that a breath hold time that's too short or too long can monkey with the diffusion capacity as well. And as we talked about when I showed you what the hatch box means, sample collection occurs too early, means less time for carbon monoxide to absorb, and then it leads to a falsely reduced diffusion capacity. So what leads to a falsely elevated DLCO? Well, this is something called a Mueller maneuver. So this is just the opposite of a Valsalva. If somebody sucks in on that valve, you can see that the pressure line here drops below the 0 line and then comes back up here. This Mueller maneuver will actually help draw blood into the chest, ultimately into the lung, and then lead to an increased, falsely so, diffusion capacity. So the second one is the expiratory volume doesn't reach the 0 line. So you can see here that this is staying above the 0 line. That means the patient started the maneuver below residual volume. And there's still more gas with carbon monoxide that should have been exhaled. It's sitting in the chest. It's not been absorbed. It just hasn't been blown out either. So that's going to lead to the falsely elevated diffusion capacity. The other thing that can do this is an exhaled gas leak. So if the mask doesn't seal against the patient's face when you're doing this, or the mouthpiece doesn't seal against the patient's mouth and you have a leak, that means you will not be exhaling carbon monoxide into the system to have it checked, and that will lead to a falsely elevated diffusion capacity. The last one I'll point out, I pointed out a little earlier, if you draw the sample collection too late, that gives more time for carbon monoxide to absorb and then lead to a falsely elevated diffusion capacity. Just like in spirometry, the lower limit of normal for patients is below 80% predicted. Please do not use an absolute value. Confidence intervals that we use are based upon a study done by Miller in 1983 in Ann Arbor. As you can also see here, that the diffusion capacity, the lower limit of normal will also decrease over time. So if you look at a 6'2" male, as this person gets older, their diffusion capacity will decrease over time. And the lower limit of normal will also decrease over time. Probably the most common question I get asked is, well, what represents a change in diffusion capacity from point A to point B? There's really no good studies to help identify the answer to that question, but I'll refer you to this study published in Chest in 2003. PFT records were reviewed from select patients who underwent Spiro and a DL measure during the same visit. They used a quality test, so the inspiratory breath had to be at least 90% of the vital capacity. The breath hold time had to be between 9 and 11, and there had to be rapid inspiration. The reproducible measurements were defined as two measurements that were within 10% of the average value, and 98% of the patients met these criteria. What I'll point out to you is over here, is that you can see the absolute difference for diffusion capacity maneuvers across the same patient on the same day. 90% of them were within 2 of each other. And if you're a percentage person, 4.05%. Now, this doesn't say that from time point A to time point B that just should be within each other, but a rough estimate of 2 and 4.05. Now, Dr. Morris has done studies here that he's looked at time variation, and that difference is probably closer to about 1.7 than it is 2. So some people will tell you 1.7 is the value that we should be using as defining as change in diffusion capacity from time 1 to time 2. So inspiratory and expiratory muscle forces, this is how I'll end my talk today. So when you order respiratory muscle forces, you get lots of data, including maximal inspiratory pressure, some people call that MIP, and maximal expiratory pressure, that's called MEP. You also use this in conjunction with the maximal ventilatory volume, or MVV. This is a gross screening for neuromuscular disease and dyspnea associated with abnormal PFTs. So you can see this in a variety of neuromuscular disease, including diaphragmatic paralysis, multiple sclerosis, ALS, and neuromyopathies. So when you look at muscle forces, the characteristic abnormality is in inspiratory muscle weakness is a low vital capacity. It's by far the most common abnormality you're going to see when you look at these patients. As you can see here, this is 25 patients with neuromuscular disease. They looked at vital capacity, functional residual capacity, residual volume, and total lung capacity. So you can see here that the vital capacity in the normal, or excuse me, in these patients is lower than that of predicted with a p-value of 0.001. But you'll also notice that the residual volume doesn't change at all. So these patients have reduced vital capacities, but no change in residual volumes. This is dissimilar to individuals that have restrictive lung disease related to restrictive lung disease from parenchymal lung disease. Those individuals will also have a low residual volume. The other thing to pay attention to in these individuals is the vital capacity changes in both the recumbent and the upright position. So you can see here, the upright vital capacity is about 2.5 on average, but the supine vital capacity drops to 2.12 with an absolute change of about 11%. So these are things that our neuromuscular team will look for in individuals on how their ALS is progressing. They'll ask for both supine and upright pulmonary function studies, which is difficult without a portable spirometer. The maximal voluntary ventilation, or MVV, is the amount of volume that a patient can breathe over a specified time period. Typically, we ask them to breathe 12 seconds for normal subjects and multiply that number by 5. A normal value is typically 40 times the FEV1, but I'll urge you to make sure that you correct. So in this patient here, they have normal spirometry, but their MVV is labeled as low at 65, which is 70% predicted. But in this case, if I take their actual FEV1 of 1.79 and multiply it by 40, that'll give me a predicted value of about 72, which gives you about 90% predicted, which is closer to normal. MVV can be reduced in obstructive, restrictive, and neuromuscular disorder. It's also incredibly dependent on effort. So if a patient doesn't give you a good effort for 12 seconds, the number is going to be low. And the problem, one of the major problems with this measurement is that there are very few reference equations to know what normal is. In this case, this patient has a normal vital capacity, arguing against the myasthenia gravis that were given a diagnosis when they come in as being significant. And when you measure respiratory muscle forces, they're completely normal. So what are the respiratory muscle forces? The MIP and the MEP. These are static respiratory measurements that give you a non-invasive way of assessing respiratory muscle strength. The MIP is sometimes referred to as the PI max. The MEP is sometimes referred to as the PE max. Remember, the MIP is initiated at residual volume. So you want to have the most air that's available to inhale to generate the largest force possible. And the MEP, you want to generate the largest force possible when your lung is completely filled. The predicted values for both MIP and MEP vary with age and can provide insight regarding progression and regression of neuromuscular disease. Similar to the MVV, they are exquisitely effort dependent. If your patient doesn't give you a good effort, the numbers are going to be meaningless. Okay, so now that I've completed telling you what PFTs are and what they do, I'm going to tell you what PFTs cannot do. They can't give you a diagnosis. They can show you a pattern, but they can't give you a diagnosis. They can't tell you if the degree of the abnormality explains what the patient's symptoms are. Patients who are labeled as normal doesn't exclude the presence of disease, and an abnormal test may not actually represent a loss of lung abnormality, may not represent lung abnormalities. Lastly, PFTs can't tell you if the abnormality is secondary to a pulmonary cause or to an extrapulmonary cause. So conclusions. Lung volume measurements and DLCO determinations are valuable adjunct tests to evaluate patients with lung disease. They're really important to figure out what's going on with your patients. But each test has a pitfall, some of them more than one pitfall, and should be interpreted with understanding where the pitfalls occur. If you don't know what the values mean and how they're gotten, then you're not going to know if they're accurate or not. And lastly, and most important for our patients, treatment decisions using these tests without denoting a proper clinical context and understanding if the test is an accurate one might lead to an incorrect assessment and the wrong treatment. So that is all I have for today. I'd be happy to take any questions that anyone may have. A question? Yeah.
Mike, is there a reason why we don't report the confidence intervals on our report and we just flag red and black whether the value is abnormal or not when we're not following percent predicted?
So the confidence intervals are actually, they're reported but indirectly. So they're labeled, the normal value will tell you what the normal value will tell you what that is. There's a document on HFH Pulm that will tell you what the confidence intervals are specifically, but the more information you put on a PFT, the less likely it is to, for people to actually be able to interpret it. Not necessarily us, but less other people are going to be able to interpret and understand what it is that they're looking at.
My thought process was you're going to send that report to the patient with different healthcare facilities or different primary care physicians, and so they're going to look at the numbers. If they don't have the confidence interval, they may not understand how did we come up with that conclusion that
So,
this is enormous geometry when to them it might not look like enormous.
So at the bottom of the test, it'll tell you where we get our normal values from. So we use the NHANES data set for individuals for spirometry. For volumes, we use Intermountain Thoracic Society. And for diffusion, we use Miller. So that's all listed at the bottom of the test. And the confidence intervals are readily available on those specific documents. I suspect that part of a pulmonary fellowship and pulmonary training is you should understand what normal values mean and where we get abnormality from. But I think putting more there's already 1,000 numbers or 100 numbers on that test, on the test sheet. Putting more numbers on there is probably going to create more confusion than putting fewer numbers on there. I'm sure Dr. Morris has many questions, but let's see.
I asked him if he wanted to be unmuted. There we go.
Is he tough? Oh yeah, I'm sorry, Libby, please.
So the other question is, we use the airway resistance parameters to, to help us with the diagnosis of, let's say, emphysema, COPD, so on and so forth. Has this been looked at for evaluation of central airway narrowing, such as tracheal stenosis? We typically look at the flow volume loop, and we look for blunting of the inspiratory or expiratory loops. But has this, did we look at the airway resistance as a physiologic measurement, whether it indicates the degree of stenosis, and helps us with monitoring and follow-up?
I don't know of any studies that do that. I mean, they may be out there. I don't know of any studies that look at it for central airway obstruction. Remember, you'd have to do volumes in those individuals in order to get an airway resistance on them. And I'm not certain if that's ever actually been formally done. Anybody else? All right. Thank you.
Very much.